It's the uOttawa's Community Service Learning Project, Ottawa Community Service Learning Student Projects. So for the past 5 years, we've been involved with uOttawa's Community Service Learning. Students participate in structured volunteer activities that meet specific community needs and are linked to course learning. They actively and strategically reflect on their experience to increase their understanding of their area of study and their sense of civic responsibility. As an organization, we get great data, great project ideas. It's a win-win. So this year we were fortunate to have 7 students on 5 projects. I'd like to introduce Brooke and Sydney for the first one.
We didn't have time to do the bio.
Hi everyone. Is that loud enough? I'm used to doing things virtually, so this is kind of new. My name is Sydney Rossiter, and this is Brooke Davis, and we are student evaluators at the University of Ottawa, here to present our program evaluation for the Vista Center. So we'll start by providing a bit of context for our evaluation, so what the Vista Center Day program is and why we chose to evaluate it. We'll also talk about what our methods and results were, and ultimately what our recommendations are going forward. So the Vista Center is an organization that works with clients with acquired brain injury, as you all probably know. They work within the Ottawa and Cornwall regions, so they are looking to expand. They have a day services program, which hosts activities for clients. They have games, they have social activities, they have exercise activities, and importantly, all the activities are developed in collaboration with clients, with the ultimate goal of promoting community integration and skill development, while also encouraging relationship building between clients. So for our evaluation today, we will be focusing on the virtual and hybrid format of the day program. So Vista had to quickly pivot all of their activities online when the pandemic hit in 2020. So everything was hosted online. And then later on, they were able to introduce a hybrid mode where they had some participants participating in person while other participants participated virtually in the same activity. And now they're wondering if there's a long-term place for the virtual and hybrid program as part of the day program in a more permanent form. So do clients like the virtual program? Do they like the hybrid programming? Or was this really just something that they participated in because of the weird conditions thrust upon us by the pandemic? So we've opted for a needs assessment style evaluation to see if this virtual and hybrid programming serves to meet the needs of clients more long-term.
Okay, so in order to get at the objectives of our evaluation, we identified 3 overarching questions. The first one is focused on understanding who the current and potential clients are of the virtual and hybrid day services. The second is looking at what those needs, interests, and preferences are of the clients. So needs being potential challenges or accommodations that need to be made. Interest, more broadly, what kind of programming would be interesting, and then preferences is focused on more logistical questions like timing, duration, frequency, that sort of thing. And our final question was trying to get at the extent to which clients are enjoying the virtual and hybrid services. So we used, it's called a mixed methods approach. We used 6 different data collection tools to try and collect enough data to answer these kind of 3 big questions. The first one is we asked alternative service providers, so other providers of day program services, about their experience offering this type of programs. We got about 6, actually exactly 6 responses back from providers. We surveyed staff as well at Vista to get a feel for their response to this type of programming. 3 staff responded. We got 28 clients to respond to the client survey, and that was probably one of our biggest collection methods. It included a bunch of questions about interests, experience, et cetera, et cetera. We also had a client focus group. We held 3 different sessions with 7 different clients to try and brainstorm and hear more about their experience. We did a review of Vista's records to get a better feel for the data they had about their clients. And finally, we looked at some sort of publicly available information to better understand clients, who they might be, where they are, et cetera. Okay, so findings. I don't have time today to go through all of our findings. We found quite a bit, so I'm just going to hit the high points. The first question was focused on understanding the clients. And so this data comes from, oh, I'm going the wrong way. This data comes from Vista's database that they collect on their clients, and we looked at comparing the client age range for the clients that participated in person and the clients that participated virtually. And I think what's interesting here is that basically you can see clients of all different age categories participating in both kinds of services. Perhaps there was a consideration that maybe some clients might not be as tech savvy, certain age categories might not be as tech savvy. But you'll see here actually in the older age categories, there was a jump in clients that participated virtually. So there doesn't seem to be evidence that clients are opting out in any specific age category. We also looked at the self-identified gender of clients, and you can see here that both in Ottawa and Cornwall locations, it's predominantly male clients that come to the in-person services. Interestingly, when we looked at the virtual services, we saw a higher proportion of women clients. What that means, I'm not sure, but it is interesting that perhaps women are opting more into the virtual virtual services. So our next question was focused on understanding the client's needs. This slide here summarizes the data we found on what clients described might be challenges that would affect their participation. You can see that attention-related challenges are the biggest, or sort of most frequently endorsed challenge that clients identified. But I think the key takeaway here is that across all modes of service, there were challenges. There's no one service that solves everybody's problems. So in terms of program planning, something that program designers need to keep in mind is that there's always going to be challenges that need to be considered and accommodated to ensure clients can participate. So finally, I'm not there yet. We also looked at clients' interests and trying to find out what clients might be interested in participating in. If clients aren't interested, they won't come and they can't benefit. So we tried to develop a list of kind of inspiration for program developers. Here are 11 categories that clients endorsed, at least 50% of clients endorsed as something they're interested in. And you can see it's a wide variety of different things. Strength training, arts, crafts, games, gardening. So I think there's a lot of different areas where clients are demonstrating some interest that program designers can draw from. And now the final finding I'm going to present is about client experience with virtual and hybrid. So we asked clients about what they thought of the different types of programming in terms of how much they enjoyed it, how interesting they found it, whether they found it an opportunity to connect socially, to learn new skills, and to develop their personal physical strength. So again, on the left here, the pink bar, that's the highest bar for every answer, meaning clients most strongly rated the in-person services for all these 5 variables. But I think what's really interesting here is that if you look at the next bar, the virtual bar, that's the second highest, and in fact, it is not statistically different from the in-person services, suggesting that when clients participate virtually, they're getting a lot of benefits out of it. The hybrid services were rated lower, suggesting that perhaps maybe there's room to tweak those to better address them, or maybe there's different areas in which clients are benefiting. But interestingly, clients really are genuinely benefiting and enjoying the virtual services almost perhaps as much as the in-person.
So our first recommendation based on our findings is that Vista Center continue to offer virtual services in addition to the in-person services. So again, as Brooke said, not only did it seem that clients were as interested in enjoying the virtual participation as at about the same rate as the in-person participation, but there seems to be a gender bias in terms of how people choose to participate. Additionally, in terms of logistics, virtual programming gives clients the opportunity to participate even if they live fairly far from one of the centers, or if they have challenges with transportation or challenges with mobility. So it does open up participation a little bit more based on that. And very importantly for the Vista Center program goals, the virtual programming does seem to promote connection between clients, which is ultimately one of the goals of the program. Our second recommendation would be to use the hybrid services as a contingency tool to facilitate ongoing access to the program if clients wouldn't otherwise be able to have access. So I'm thinking like inclement weather or, God forbid, more COVID shutdowns or anything personal that would prevent them from coming in. Well, we found that clients didn't necessarily enjoy the hybrid activities as much as they did the virtual or in-person activities. They did very much prefer it to having no access to the activities. So we recommend allowing clients to potentially call ahead and request to be added virtually into the in-person programming. So essentially having a little bit more flexibility with how the in-person programming is run rather than having a standalone hybrid program. Given that clients said that participating in person in hybrid activities wasn't negatively impacted by participants who were joining virtually, we think that this is a very good win-win. And then, oh sorry, go back. And then another great use of the hybrid model would be to use it as a tool to introduce new clients to the programming, especially the in-person programming. So essentially allowing new clients to sit in on an in-person activity and get a sense of whether or not this is something that interests them or meets their needs. It might be great for new clients who are a little bit more shy or wary. And this was actually a recommendation that came directly from one of our clients, and we really appreciate it because we thought it was a really awesome idea. And our third recommendation would be to put in place a quick measure of satisfaction to facilitate information gathering on clients' experiences on the programming. So although one of the aims of our evaluation was to get insight into clients' experiences, we weren't able to get a lot of information on the specifics of experience. They gave us a lot of general information, but I think there were some memory challenges that posed an issue to gathering very specific details on the experience. So we recommend having a very accessible survey box available for clients that allows them to provide in-the-moment feedback on an activity while they're participating in the activity or immediately following the activity. So this might be a better way of obtaining valuable information and feedback for staff who are running the programs, and it might help facilitate program development going forward. So that's the end of our presentation. If you guys have questions, let us know, or you can talk to us after. Do we have time for questions? Come talk to us after, sorry.
We're on a tight schedule. Okay, I'm going to call Jacob and Taylor. Taylor's virtually, but Jacob's coming.
And where are you going? None of your business.
Okay, so today we're going to be presenting our project on affordable, healthy meals for individuals with acquired brain injuries. So, do I have a clicker? There we go. So, as I said, my name is Jacob, and I'm from Ottawa. I'm a first-year medical student at the University of Ottawa. My colleague Taylor, she's from Sault Ste. Marie. This is where she'll be joining us from today. And she's also a first-year medical student at the University of Ottawa. So, okay, so why is this research important? And so it's because the challenges to healthy eating, especially in the past couple of years, have really been trending upwards. And so particularly for individuals with acquired brain injury, they face additional obstacles when it comes to a healthy diet. And so we really aim to identify those obstacles in order to be able to offer better services. So here we have the goals we wish to explore with this research. So first, we wanted to look at the living situation and the finances. And so like if people have access to different kinds of cooking appliances, what their budgets are, if they can afford groceries. Then we also looked at the level of autonomy. So we wanted to see if people with acquired brain injuries did their own groceries, if they cooked their own meals, and how they commuted to the grocery store. We then looked at the diet. So we wanted to see if they use like services like food banks, if they adhered to the Canadian Food Guide. And lastly, we also looked at the lifestyle, so like exercise, alcohol consumption, and smoking tobacco. So the method we used, we elaborated a survey on SurveyMonkey, and then we sent the link to the Business Center, and they distributed it to their programs. And so all participants received a compensation from Tim Hortons. We had a total of 31 participants, most of which were 45 and older. So in terms of the population who answered our survey, I did a little map here showing that most of the respondents were in Ottawa, but we also had quite a few from Eastern Ontario. Okay. So when it comes to the respondents, it was almost a 50-50 split between people living alone and people living with others. I mentioned cooking appliances. The respondents, there was no evidence that there was a lack of cooking appliances, and most of the respondents did not live in a long-term care facility. So now, to some of our results. So in terms of financial results, one of the most important statistics that we have is that about 57% of our respondents lived on a preset monthly budget, and so this definitely can have an impact on, well, it can put a limit when it comes to grocery shopping. We also looked at rent, and most people did not have difficulty meeting rent deadlines in the last year. And about a quarter of our respondents use services such as food sharing services or food banks. Over here, again, with finances, about 60% of our respondents had difficulty setting aside sufficient fund for grocery at least a few times in the last year, and so this was definitely one of the most significant stats that we got from this survey, and I think it really demonstrates one of the key limits from this survey. We also questioned to see if most people had access to a credit card, which they did. And here, for autonomy and accessibility, 59% of our respondents did have some form of limited mobility. Some use wheelchairs, other walking aids. But most people were able to do their own groceries and also cook at home. And in terms of traveling to the grocery store, about half the respondents had their own cars, but some did use a paratranspo, walked, or other forms of transportation. Now I'll pass it along to my colleague Taylor.
Hello everyone. Hopefully the video and audio are coming through okay. Can everyone hear me okay?
Yeah. All right. Who had that?
Hopefully. Yes, perfect. Okay. So I'm just going to continue to talk about some limitations when grocery shopping. So although just under 40% of our participants reported having no limits to grocery shopping, many did report limits such as, for example, bag limits on paratranspo, limited ability to transport their groceries, difficulty with the time of year, for example, when it's winter out, especially for those who walk, bike, or take transit. And then many others also listed challenges that they found that were unique to them. For example, limited space for grocery bags, grocery store setting induced PTSD, anxiety, difficulty at the cash, and similarly, the increased light and noise of the grocery store environment. And as for diet, we wanted to just get a taste of what our participants' diets were like. When asked whether or not they eat 3 meals a day or less, about 50% of our participants reported eating less than 3 meals a day, which was quite shocking and concerning as well. And then likewise, about 50% reported trying to follow the Canada Food guidelines, but about 50% reported either not being able to follow the guidelines because of restrictions, for example, budget, or just not considering it an important part of their daily lives. So yeah, we had about a 50-50 split for those two questions. And then just continuing on with the diet, we found that most of our participants do not follow a diet, so about 71%. And then also 32% reported having some sort of dietary restriction. And these would include things like gluten sensitivities, dairy sensitivities, or other medical conditions, for example, IBS or gastrointestinal conditions. And many respondents also reported eating only 1 serving or less of fruits and vegetables per day, with that being about 60% of our respondents, which was also a concerning finding. And then continuing on with diet and lifestyle, we found that ordering food or the consumption of pre-prepared foods was not abnormally frequent in our participant population. And we also found that about over 80% did not smoke or report consuming alcohol, which was positive, of course. And about 46% of respondents reported eating snacks late at night, closer to bed than dinner, which can contribute to an unhealthy diet, especially if those snacks are unhealthy ones. And then about 81% of our participants responded and said that they consume regular amounts of sugary drinks, which also contributes to a less healthy diet. And just continuing on with the lifestyle, we asked our participants how many hours per week they're able to exercise, and about 1 to 3 hours per week seemed to be the most common answer, with only about 22% reporting not having any exercise at all on a weekly basis, and about 90% of our participants reported that do exercise reported about low to medium intensity exercise. And then overall limitations, when we asked our participants what their biggest obstacles to healthy eating was, about 40% responded something to do with the increasing prices of groceries, and that was sometimes in terms of quantity, not being able to purchase enough food, or quality, not being able to afford the healthier options. And then others cited mental health, willpower, lack of energy, fear of insufficient food for their children, convenience of eating those unhealthier foods, and also difficulty limiting intake as limitations. And in conclusion, we found that food prices were the main factor that contributed to difficulty eating healthy, among others as we discussed. And these factors have a significant impact on those living on strict budgets, such as many of the members of our participant demographic and our respondents. And factors more specific to our target population included limitations that we discussed, such as the paratransport bag limits and limited mobility. And then lastly, mental health and motivational and other willpower-related struggles also contributed in our target population as reported by them. And then overall, we hope that this research will demonstrate the struggle to eat healthy for those with acquired brain injuries and outline some of the target areas that we can basically take action on to improve these areas and support our participant demographic.
And
we just want to thank you for your attention, and have a great day.
Okay, so hi everyone, my name is Justine. I'm also a medical student at the University of Ottawa, and so I worked with the Vista Center this past semester to look at seasonal affective disorder and brain injury. And basically what I found when doing a bunch of research online on these topics was that there's a lot of info on seasonal affective disorder, there's also a lot of info on brain injury and affective disorders, but not a lot of information on specifically seasonal affective disorder as it relates to brain injury. And so with that, I thought it'd be a good idea to kind of come up with an idea of a bit of a pilot study looking at specifically seasonal affective disorder in a population with brain injury. And so I came up with this little project here that we hope to implement next year with next year's students. And it's called Investigating the Relationship Between Seasonal Affective Disorder and Traumatic Brain Injury using the Seasonal Pattern Assessment Questionnaire in patients at the Ottawa Vista Center for Brain Injury Services. So I'll walk you guys through a bit of the research and the facts and literature that I found on these two topics here. So if you look at traumatic brain injury and affective disorders, about 50 to 60 million people worldwide are affected by traumatic brain injury each year, and it's estimated that about 50% of people in their lifetime will actually acquire some severity of traumatic brain injury. Also, up to 40% of people who acquire a traumatic brain injury will suffer from 2 or more psychiatric illnesses following that injury. Like I said, there's a lot of literature on affective disorder and traumatic brain injury, and I think Armand touched a bit upon it. So there's a clear association between traumatic brain injury and subsequent Axis 1 affective disorders. So some example of those disorders are things like major depressive disorder, post-traumatic stress disorder, and also anxiety disorders. And a cool fact here that I added in the presentation was that patients with all severities of traumatic brain injury are actually at a higher risk for developing traumatic brain injury related affective disorders. So it could be things like mild concussions that can actually give you a higher risk of going on to develop an affective disorder. And then if we look at seasonal affective disorders, this in the DSM-5 is a subtype of major depressive disorder, and it's characterized by at least 2 episodes of major depressive disorder within the past 2 years that follow a very obvious seasonal pattern, and there's actually full remission of that depression episode at the end of the season, and is most commonly associated with the winter months. Seasonal affective disorder has a lifetime prevalence of 0.5 to 2.4% in the general population. And so this study will actually be one of the first to specifically look at seasonal affective disorder in a population with traumatic brain injury. And so will help to add to the knowledge, add to the literature available on mental illness implications following a traumatic brain injury. So why investigate the prevalence of seasonal affective disorder in a population with traumatic brain injuries? Like I said, it hasn't really been done before, so we're looking to add to that knowledge. And properly knowing, properly targeting, and acknowledging the disease suffered post-traumatic brain injury will actually help to determine the amount and type of resources needed for the people suffering from this. Also, cognitive impairment post-traumatic brain injury is one of the largest barriers to reintegration into the community. It is actually a very big challenge for independent functioning, hence the need to properly identify and properly treat these issues that can surround traumatic brain injury. There's also a biological basis to look at specifically seasonal affective disorder and traumatic brain injury, and that is kind of the shared disease mechanism between the two that seem to play into a functional and quantitative impact of serotonergic pathways within the central nervous system. And so if we look at some facts on that, we see that there's decreased serotonin levels in the human brain depending on the season, with a minimum of serotonin levels in the brain during the winter months, so in December and January. We actually see that there is a higher serotonin receptor availability in the brain, and that's correlated with the period of longer days, so more sunlight, and you would have a higher availability of receptors to capture that serotonin within your brain. We also see that patients with seasonal affective disorder have an upregulation of SCRT in the winter. So SCRT is a serotonin transporter, and it's responsible for actually uptaking serotonin within your synapse. So it's a bit counterintuitive, but more SCRT equals less available serotonin. So we see that people with seasonal affective disorder have more SCRT, especially in the winter compared to healthy controls, and so that leads to less serotonin available. And then we also see that serotonin is a key neurotransmitter involved in the neuropsychiatric outcomes of traumatic brain injury. And that's obvious by the fact that it's actually a very big pharmacological target for people suffering from this. So for example, SSRIs, which are selective serotonin reuptake inhibitors, will play directly on levels of serotonin in the brain. That's a pretty common treatment that people may be on. We also see that TBI causes dysregulation of neurotransmitter synapses in the brain, and this is particularly evident in the frontal lobe. So the frontal lobe is an area of high concentration of serotonergic projections, and so we see that especially with injury to the frontal lobe, we actually see less available serotonin. Lastly, a fun fact here is that severe traumatic brain injury has been associated with as much as a 17% loss of serotonin neurons in the CNS. So here the objective really, like I said, is to investigate the correlation between seasonal affective disorder and traumatic brain injury in a population from the Ottawa Vista Center for Brain Injury Services. Our hypothesis is really based on the shared pathophysiology of seasonal affective disorder and traumatic brain injury, and also based on the literature that shows an evident correlation between traumatic brain injury and affective disorder. And so our hypothesis is that we will see a significant positive correlation between seasonal affective disorder and traumatic brain injury. So our participants will be traumatic brain injury patients from the Ottawa Vista Center for Brain Injury Services who received their TBI diagnosis in the past 5 years. And that's based on a study that showed that after 5 years, the incidence of affective disorders in patients with traumatic brain injury significantly decreases. So ideally, we would look at patients who have received their diagnosis in the past 5 years for their TBI. And then exclusion criteria would include actively taking antidepressants and past or current alcohol abuse. And that's just because these things are things that would actually affect the amount of serotonin in your brain. So we would use the seasonal pattern assessment questionnaire in a survey to the participants. So this is a widely used screening tool for seasonal affective disorder. It has a good specificity of 94% and a good internal consistency at 0.85. It's also ideal for us as students coming in onto a new project since there's no training required to administer this tool, and that patients and clients can actually just fill it out themselves and they don't need to be with a healthcare professional in order to properly fill out this tool. So the way it works is on question 11, there are about 6 items and they range from 0 to 4. And so the global seasonality score is the score of the sum of all of these items on question 11 of the questionnaire. And so obviously it can range from 0 to 24. In the general population, the global seasonality score seems to be about 5. And in patients with seasonal affective disorder, the average is about 16. However, if you are positive for seasonal affective disorder in this questionnaire, your global seasonality score is actually 11 or higher. And then on top of that, you would also need to answer moderate or higher on question 17. So question 17 is, if you experience changes with the seasons, do you feel that those are a problem for you? And if your answer is moderate or higher, along with the global seasonality score on question 11 of 11 or greater, you're screened as positive for seasonal affective disorder with this tool. And then so in the results, obviously we don't have any results yet. We hope that by this time next year, we'll have a good idea of what those results would look like. But it would be a correlational study to test the relationship between seasonal affective disorder and traumatic brain injury. And like I said before, we expect to find a positive correlation, even when controlling statistically for certain confounding variables. So these variables would be things like psychiatric illness prior to traumatic brain injury. And that's based on some studies that show that having a psychiatric disorder pre-injury is strongly correlated with developing a new psychiatric illness post-injury. We'd also look to control for things like the sex. So for example, women have a 1.5 times higher prevalence of seasonal affective disorder than do men, and things like age. So a study that also used the SPAQ found a significant negative correlation between age and the global seasonality score of their participants. That being higher the age was, the lower the global seasonality score. And so I'll go a bit on our limitations and future directions that this study could have for people looking to expand on it. So some limitations is while the SPAQ is a widely used screening tool for seasonal affective disorder, it has been shown that it will sometimes overestimate the true prevalence of seasonal affective disorder by failing to distinguish people with seasonal affective disorder from people with depression who do not actually have that seasonal pattern to their depression. Also, our study uses a retrospective technique, so you'd be answering a questionnaire, which is always subject to some recall bias. We'll be controlling a bit for this by implementing the questionnaire in the winter when these symptoms seem to be most prevalent, as opposed to, asking questions on seasonal affective disorder in the summer where you may not be experiencing these symptoms. And then lastly, due to the correlational design of the study, we can't actually say that traumatic brain injury will cause seasonal affective disorder. We can only investigate and characterize that relationship. So some future directions for this study, because the SPAQ, like I said, has that limited ability to distinguish seasonal affective disorder from depressive patients who do not have seasonal affective disorder. Future studies could also look at adding a depression scale into their survey to properly distinguish the two. So things like the BDI could be added into the survey. They can also look to use the DSM-5 diagnostic criteria as opposed to the SPAQ. The main reason why we wouldn't be doing that is because there's that time frame in the DSM criteria, so at least it's depressive episodes for at least 2 years, whereas we would also be hoping to also have participants who may have received their TBI diagnosis only 1 year ago or less than a year ago. And lastly, a big part of our study here is based on the fact that there's this shared pathophysiology between both diseases involving serotonin. So it'd be interesting for future studies to use some imaging techniques, such as like PET scans, to actually quantify the amount of serotonin in the brain for patients who have suffered a traumatic brain injury, to either accept or reject that hypothesis that the serotonin levels actually do play a major role in the pathophysiology of these diseases. So thank you so much for your time. I don't think I have that much time for questions, but if you have questions, please find me after.
All right, hello everyone. My name is Maritza and I am a first year medical student at the University of Ottawa, and today I'll be discussing some potential treatment options for patients with traumatic brain injuries or TBIs and comorbid depression, specifically seasonal affective disorder. All right, so I will begin by just giving a little bit of a background. I'll go through quickly because I'm sure you've heard this several times today. So if we start with traumatic brain injuries, so there's two different types. There's either penetrating or non-penetrating, and there's several different signs and symptoms associated with TBIs. Specifically, there is, for physical symptoms, there's headaches, convulsions and seizures, vision problems, nausea, neurological deficits. Cognitive symptoms include changes in level of consciousness, confusion or disorientation, problems with memory, sleep changes, increased frustration, and irritability. And lastly, there is also associated symptoms of lightheadedness, hearing problems, bad taste in the mouth, light sensitivity, mood changes, and fatigue. In terms of depression, there's a few different categorizations, but I will specifically be focusing on the specifier of seasonal depression, which has a temporal relationship between the symptoms of depression and the time of the year. It also includes a full remission. So generally the seasonal affective disorder tends to show up during the winter. This is just a general overview. So after a TBI, there are several psychological changes. So specifically, patients who have TBIs have a higher chance of developing or triggering schizophrenia, depression, or bipolar disorder, especially in the 11 to 15-year-old age group, which is possibly because this is an important time for neurodevelopment. As mentioned before, the seasonal affective specification is usually associated with major depressive disorder, and it was first described by in a 1984 study. And so there isn't that much information on the actual link between seasonal affective disorder and TBIs. However, there is quite a bit of literature on major depressive disorder, so a lot of what I'm going to be proposing is going to be based on these findings from major depressive disorder. So firstly, with a TBI, there's often sleep changes. So in general, patients with TBIs experience more but poorer sleep. And as you might have heard, depression has similar effects on sleep. So I kind of hypothesized that these two act together. So a TBI makes the patient more tired, which might trigger other depressive symptoms. So now I'm going to discuss current therapies for depressive symptoms in TBIs. And generally, we go with pharmacological therapies. So generally, they start off with lower doses of medication because patients with TBIs tend to have worse side effects. Specifically, SSRIs are probably better than MAOIs. And interestingly, a 2021 study showed that methylphenidate might be the best course of action for patients with depression and TBIs. But again, this is not specific to seasonal affective disorder, so more studies would need to be done in this area. So again, there's very little information. So one of the only case studies I could find was one from 1990, which talked about a woman who had a traumatic brain injury, and she began experiencing symptoms of SAD, and she was treated with lithium and imipramine. There's also non-pharmacological therapies, so there is possible evidence showing that blue light therapy specifically might have good short-term effects in improving symptoms. My project specifically was to suggest ideas for interest groups, and so I decided to look into this blue light therapy and found that it had an overall positive effect on patients with TBIs and SAD, and it would be well paired with cognitive behavioral therapy, so CBT, specifically for sleep disturbances. So now my study proposals. There are two. The first one is yoga. So there has been a link between decreased levels of neuroplasticity and depression, and one study that I looked into showed that yoga could help improve psychosocial functions and neuroplastic effects. So that could possibly have an effect on the depression. It could also be helpful for chronic pain, which is often experienced by patients with TBIs, and specifically those who have recently experienced a TBI. Yoga with self-compassion was correlated to lower rates of long-term disabilities. Additionally, yoga helps with interoceptive awareness, which I believe is especially important for patients suffering from TBIs, since injuries of any kind can take some bodily adjusting. Yoga has been shown linked to decreased symptoms of anxiety, which could be beneficial in mitigating these symptoms in patients with TBIs. So I'm proposing two different methodologies, one for people who can stand and one for wheelchair-bound patients. So the specific protocol that I looked into is based off of a 2016 protocol, which found that patients experienced a significant decrease in self-reported anxiety symptoms, increased interoception, and better pain management. And this protocol was paired with lectures on different areas of yoga, such as self-compassion, so outside of just the physical movement. I also found a protocol that was adapted for wheelchair users. So this study used 3 times a week, 60-minute yoga classes, and it showed to have similar effects as the previous study that I mentioned. So since many of the symptoms are self-reported and based on the practitioner's skill level, it is difficult to propose an exact protocol that would work for everyone. However, a 2012 study suggests that younger practitioners might require more practices per week compared to older patients. And the same study shows that the best outcomes were experienced by patients who practice 5 or more times a week, which is why my protocols can be easily adapted for home practice. So one important consideration is that since patients with TBIs experience more dizziness and headaches, it is possible that some of the poses can either be inaccessible or inadvisable. And since the 2012 study that I mentioned before concluded that it is the act of yoga that, as opposed to any specific pose, that has the best effects, so protocols can be adapted to fit each person's needs. The second study that I'm proposing is to use light therapy. So there are different types of light therapy. Specifically, red light therapy was shown to improve symptoms of fatigue during the day, whereas blue light symptoms might help more with other depressive symptoms. So lower brightness for longer exposure time might be more beneficial to patients with TBIs due to photosensitivity. Additionally, according to a 2019 study, doing this light therapy after waking up has been correlated with best results. So my suggested protocol is that patients be exposed to light in the morning with light boxes that have an intensity of about 10,000 lux for 30 minutes each morning, or 2,500 lux for 1 to 2 hours each day, although a limitation to this is that there might be lower rates of compliance because not many people have an hour to 2 hours a day to do this. So one really important consideration for patients with TBIs is the photosensitivity. So it is probably better to start off with longer sessions that have a lower brightness and see how the patients are working from there, and then adjust accordingly. All right, now the conclusion. So in conclusion, there are many different therapies that can be used in conjunction with traditional pharmacological approaches. And I proposed 2 different protocols which I would be excited to see explored with an interest group. Thank you. Does anyone have any questions? Oh, yeah?
Well, can we get the mic? Just hold on, so everybody online can hear you too.
Hi. I think this research is very interesting. I'm a clinician as well as somebody who suffers from a TBI. And I've been working with Love Your Brain for over a year, and so I'm just intrigued because your yoga study seems to incorporate some of those alternative pose ideas and things that they do in their flow, and they're also online. So I'm just curious, is it something with your interest groups that you'll have trained local instructors, or are you aware of the Love Your Brain research?
So right now I'm just like proposing different
Right.
possible things we can do. I think that this will probably be handed over to a future student, but that is a very good, interesting point. So I'll definitely put that in the notes for the next student. Thank you.
Thanks.
And so let's look at the impact or consequence of the ABI. It can mainly classify into 3 categories: physical, cognitive, emotional, and behavioral consequence. It like this. Okay. And to adapt and heal this symptom, we also make lots of challenges. For example, ABI can lead to muscle weakness, either localized or generalized. This can affect various muscle groups throughout the body, making it challenging to perform everyday tasks or engage in physical activities. It has balance issue too. ABI can disrupt the body's sense of balance and coordination, leading to the difficulties in maintaining stability and increased risk of fall. This can be caused by damage to brain areas responsible for balance and the feeling of their bodies. Also, ABI can affect motor control and coordination, making it challenging to perform precise movement activities that require fine motor skills, such as writing, using implement, or like wearing clothes, may be particularly affected. So besides the physical difficulties, if people want to do physical activities, we should think about the sensory impairment issue. We also think about that, which can lead to difficulties in processing and integrating sensory information. This can lead to an overload of sensory input, making it difficult for people with ABI to engage in physical activities that involve crowded or noisy environments. An abundance of the sensory stimulation can lead to stress, anxiety, or a sensory breakdown. And some people with ABI may develop a hypersensitivity, which means they have hypersensitivity to certain sensory stimuli. For example, bright lights, loud noises, or certain materials can be overwhelming individuals, either causes discomfort or pain. In such cases, people may avoid exposure to this stimulating physical activities, thereby limiting their participation in certain sports or exercise. Conversely, some ABI people also they reduce the sensitivity to sensory stimuli. For example, they may have difficulty identifying their body position in space or maintaining balance during activities. All of the above should be considered. And the cognitive disorder is a big issue too.
ABI groups might have difficulties to understanding instructions. We may struggle to understand and remember instructions for physical activities. ABI people also might reduce planning and organization skills, can cause poor problem solving and decision making. ABI people with cognitive impairment may have difficulty assessing and responding to new or unexpected situations during the physical activities. And the last one is emotional and psychological factors. The first emotional and psychological disorder may result in the lack of motivation or interest in participating in physical activities. Also, people with ABI may experience fear or anxiety related to their physical abilities or fear of the further injury. A fear of failure or judgment from others may also contribute to their reluctance to participate in activities that involve a physical component. And people with ABI may struggle with negative self-perceptions and a lack of the confidence in their abilities. This may diminish their confidence to participate in physical activities, especially those that require physical ability or involve social interaction. Finally, there are emotional and psychological disorders that can lead to difficulties in regulating emotion, which can result in highlighting emotional responses to physical activities. Which physical activities should be chosen? Firstly, balance exercise. For instance, like slowly shift the leg spring and the weight shifting. Slowly shift your weight onto the leg. You can place the lifted foot on the ankle or cuff the standing leg for support. Throughout the exercise, remember to breathe deeply and maintain focus on your body and the sensation of through understanding different situations. Ask for professional healthcare. Ask for professional healthcare suggestion. Choose a yoga practice is appropriate to patient's condition and ability is recommended. Like here. Gentle, slow exercise are often more appropriate for patients with brain injury. It can avoiding tremors, difficult movement. Yoga practice can help people with brain injury increase flexibility and balance, improve the postural control and motor coordination. The deep breathing and meditation exercise of yoga can help reduce stress, anxiety, and tension, and promote physical and mental relaxation and mental health. Also, it can improve the concentration and focus. By focusing on the physical movement, breathing, and sensation in yoga practice, people with brain injury can improve. And the yoga practice can target strengthen the core muscle strength and stability of the body, improving muscle function and daily living ability. Vista Center offers something about that I saw. They screening the contact with each client and advance of the participation, including health history and release liability. And the exercise here are carefully selected, not only basic balance exercise and yoga, but Tai Chi and lots of equipment also. And And music is also added as a time to enhance the overall experience. So let's talk about the benefit of, that's why physical activities is important for that. Oh, sorry. For the physical benefits part, physical activity can improve the strength and endurance. Regular physical activities can help strengthen muscles, increase the strength, and improve the overall physical fitness. It also, like certain exercise and activities can target balance and coordination, helping the individuals improve their motor skills and stability. Increase also by when people do some oxygen exercise such as walking, swimming, or cycling can improve heart health, circulation, and overall cardiovascular fitness. By the way, physical activity combined with a healthy diet can help individuals with ABI maintain a healthy weight and prevent the risk of the obesity-related complications. And for the cognitive benefits part, physical activities have been linked to improve the cognitive abilities, including like attention, memory, and executive functions like problem solving and decision making. Regular exercise can stimulate neuroplasticity, the brain's ability to reorganize and form a new connection, potentially facilitating recovery and adaptive challenge after ABI. Also, physical activity release endorphin, which can boost mood, reduce the symptom of the depression or any other negative emotion. So, in the social and emotional benefits part, physical activities can participating in a group-based physical activity or sports can foster social connection, reduce feeling of the isolation, and promote a sense of belonging. It can also achieve physical fitness goals, and experiencing improvements in physical abilities can help people feel more self-esteem and confidence. Physical activity can act as a natural stress reliever, helping individuals manage stress to promote the relaxation. For the last part is secondary prevention. In this part, physical activities reduce the risk of the secondary health condition. It can help them prevent or manage that, such as cardiovascular disease, diabetes, and osteoporosis. Sorry about my pronunciation. And it also can prevention of the functional decline. Regular exercise and physical activities can help maintain the improve the functional abilities, preventing or reducing the decline in physical and cognitive functioning. So here is some suggestion. Here is some suggestion when you doing the physical activities and the Vista Center offered for clients. So. Thanks for listening. That's why it's important for the brain injury physical activities. Thank you.